morning, everybody, and greetings and welcome. So my name is Ranu Jang. I'm for some of you here, I see some colleagues from UMS who are here. So very much welcome to all of you. I'm Associate Vice Chancellor here, but most importantly, I'm the founding executive director of this fantastic Institute for Integrative and Innovative Research. And we are very, very happy and thrilled to have you all here. And this is our Convergence Hub. And officially, we are going to open next week. So this is a preview of the opening of the kind of things that we are thinking this would be. The first time news releases, the first time celebration of collective effort. So that is what we are going to look at today. So what is the Institute? So those of you who may not know a little bit about it or maybe learning about it, and those of you who are on Zoom may be learning about it, we are an institute that we say our mission is to solve wicked problems. And what is a wicked problem? Which, by the way, today there's an art exhibit going on by an MFA student on wicked problems. So what are wicked problems? Those that don't have an easy, simple solution, require complexity, and you really need to be adaptable to be able to answer those things. How do you solve them? The approach we are saying we would take is a convergence approach of bringing multiple sectors together, not just disciplines together, but multiple sectors together from industry, from government, from clinics, from nonprofits, all of that pulling together in order to be able to solve those wicked problems. And our bold vision, we want to be recognized as the leaders for doing this kind of convergence research. We are driven by purpose to deploy solutions that will have a societal impact. So that gives you a little bit about us. There are 5 words we use to try to describe our institute. One is integrative, which you have already heard in there, right? There is integrative and innovation. Convergence, we are also committed to economic development, and we want our solutions to be at scale. And finally, of course, to make societal impact. So again, we are thrilled to have you here. And let me give you another opportunity to come back next week. If you are faculty or staff at University of Arkansas, there is a preview from 9 to 11 a.m. on April 15th in the morning before we do the evening event. And then there is a community open house on April 16th from 5 to 7 p.m. You will have a chance to see part of the building and also see some of the research that is happening here. And with this, let me now introduce to you and Dr. Michael David Niño. So Dr. Niño is a sociologist. He's from our University of Arkansas, but most importantly, he has been part of a bigger effort across the entire state, especially in partnership with our colleagues at University of Arkansas Medical Sciences, in doing a statewide survey effort. I want to also recognize someone else who contributed to some of this survey, and that was a visitor who visited us, Dr. Carl Krupp from University of Arizona, that I think initially when you were starting to put out the survey, gave some input and guidance. So it is really interesting how you've been able to bring things here, but also get input from all the rest. So he's going to present to us preliminary findings from the Arkansas Health Survey. This is an important survey that will inform researchers and community leaders across our whole state, and obviously knowledge that we get about our state will go across afterwards. Dr. Niño is an associate professor, as I said, in the Department of Sociology and Criminology. He serves as the director of the Arkansas Health Equity and Access Lab, HEAL, at the University of Arkansas. He's also a faculty affiliate in the Department of Psychological Sciences, Data Science Program, the Latin American and Latino Studies Program, and the Center for Health and Technology. He earned his PhD in medical sociology from the University of North Texas, specializing in medical sociology, research methods, and statistics. And before he joined us here, he was an assistant professor at Willamette University, where he also contributed to the American Ethnic Studies, Latin American Studies, and public health programs. We are absolutely thrilled that for the first time, this data is going to be released at a seminar presentation at IQDAR. You are solving these big problems. This is just the start. So welcome.
So first, I'd like to thank Dr. Zhang for inviting me to come share some work with all of you today, but also to all of the wonderful staff here at IQDAR who have worked tirelessly to put this together. In particular, Delia Garcia and Elizabeth Muscari, who have worked with my crazy schedule, sending out invitations and kind of planning this particular event. Really appreciate it. So before I get into the survey, I think it's really important for me to provide some context in terms of how I come to the work. So yes, I am a medical sociologist, but I also grew up in the Texas Panhandle to parents who were the first in their families to graduate from high school. And my grandparents had less than a third grade education on both sides. And my grandfather on my mother's side couldn't read, right? And we grew up in a particular area surrounded by deep economic and social disadvantage. And what came with that were people that lived around the area that I knew and loved, and people that knew and loved me, that were living with and dying from chronic disease much earlier than they should have. Right? In fact, 2 years ago, we buried my uncle at the age of 58 due to complications related to diabetes. And I think I could poll this room, and I think most of you would raise your hands if I were to ask, how many of you know people who died before the age of 75, right? Or died much earlier than they should have and suffered through that death, right? That we've all been touched by these different things here, and in particular in the state of Arkansas. And so what I'm going to walk you through today is a project that hopefully will begin to address some of these issues, right? Really begin to understand what's driving population health disparities in the state. But before I do that, I think it's really important to provide some context for health in Arkansas, right? So I can show you this map. So this is a state health rankings map in the US. We receive these rankings every year. And Arkansas ranks at or near the bottom with respect to health every year. This is a persistent health ranking, right? It's a persistent health ranking. And while I think about this particular ranking often, there's a ranking that I think about even more often, and it's this ranking here, which is 43. And what this ranking represents is our premature death rate in the state. And there's a number that really underlies this ranking that I think about every day as we engage in this work. And it's this number in particular, 11,504 years. And what this number represents is the number of potential years life lost per 100,000 people under the age of 75. Right, every year in the state of Arkansas, these are the number of years of potential life loss. And I don't really think about the economic and social kind of loss of this, right? It's, while that's important, that's not really kind of the primary thing that I'm thinking about. The thing that I often think about are the number of events, the number of conversations, right? The number of interactions that we get to have with the people that we love, right? That we no longer get to have with the people that we love because they died much earlier than they should have. And most likely died from some type of chronic disease, right? Preventable chronic disease. That's important, right? Preventable chronic disease. So some of you might be asking, what do most people die from in Arkansas, right? And so this is a table of our leading causes of death in the state. So these are the primary killers in the state. And they mirror a lot of leading causes of death in other states or across the country, right? Heart disease, cancer, chronic lower respiratory disease, COVID, accidents, stroke. But what's different about our leading causes of death are the rate at what people are dying from these leading causes of death. So if you look at our state ranking, right, for heart disease, we rank 47th. When you look at cancer, we rank 46th, chronic lower respiratory disease, 48th, and so on, right? We rank at or near the bottom with a lot of the leading causes of death in the US, right? So we have a lot of folks who are dying much earlier than they should have, and they're suffering through these chronic diseases. And so as we started to engage in this work, people would ask me, they would ask Dean Williams and Dean Amick at UAMS, what do you think is driving poor health in the state of Arkansas, right? Holistically, what are all of the different kinds of drivers that are driving poor health, right? We know people are really suffering in the state, and what is it? And today, what we have to tell them is that we really don't know, right? We really don't know. That we currently don't have the data infrastructure to really tell us in a comprehensive way what is driving disparities in health in the state of Arkansas. And so I'm going to walk you through some of the current data limitations that we have with respect to public health data in the state, and then talk to you about what we're doing to address it. So currently, we don't really have data that allow us to identify and monitor Arkansas-specific health trends for all counties within the state. So we have a behavioral risk surveillance survey that will allow us to look at trends for most counties, but not all. And what's important is that when we receive these data, they're often years old, and they're only aggregated at the county level. We also don't have data that will allow us to determine whether different social mechanisms shape health differently within and across counties in the state of Arkansas, right? So we don't have individual level data to see what is actually driving these health outcomes in different places in the state. We often just have to guess, right? We have aggregate data at the county level, sometimes at the census tract level, to where we could kind of surmise what might be driving these patterns. And because of this, we're unable to really understand whether we are meeting Arkansas-specific health objectives across the state, right? When a new initiative is implemented statewide, some sort of new policy is implemented statewide, we can't really track whether or not these policies, these new initiatives are improving human health, right? Because the data that we receive are aggregated and they're often years old and we receive them. And because of this, we're unable to really provide meaningful insight to community stakeholders on how to improve human health and well-being within and across counties in the state of Arkansas. So what are we doing to address this? Well, we created the Arkansas Health Survey with the overall goal of providing a detailed picture of health and health disparities for diverse populations residing in all 75 counties. And we put together this incredible team of 16 scholars from 6 public institutions and a private industry team to reach this goal. And I'm going to talk about our amazing team here in a minute, but this is a collaborative effort. Fayetteville is playing a primary role in data collection, but UMS has also played a really important role in that collection and also survey development. So we're kind of building out the primary components of the survey, and then our team will help disseminate findings. So what did we do? Obviously, we created a survey. This is a representative population-based multimode survey, so both web and mail, with the goal of reaching the sample size of 11,000 residents in 75 counties. We have 4 primary aims. So the first being to monitor the health of Arkansans through the collection of survey data. And not just to collect survey data now, but to continuously collect it, to do this every single year, right? So this will be the second a continuous health monitoring survey of this type in all of the United States, right? So we can really begin to track trends in ways so we can begin to understand whether these initiatives are actually working or not in the state. To compile information on social determinants that shape health in Arkansas. So I always like to say that we've included kind of the greatest hits of all of the different types of social determinants that have been shown to play a role in population health, but we've never really had them all here in the state one survey instrument. So we've included those in the survey. 3, and this is one of the more exciting components, to identify community and built environment mechanisms that drive disparities in health in Arkansas. Because of our sampling strategy, we are able to link individual survey responses to community and built environment measures to begin to understand where you live, where you work, where you play, where you worship, how those different types of things actually shape health. So it is a true multi-level data tool, right? And other surveys that have attempted this have not added this extra component to the survey. 3, to create accessible and impactful data tools for stakeholder communities to address drivers of disparities in health. So we really believe in the land-grant mission here at the University of Arkansas, so do our partners, and we plan to give these data away. Right? So we plan to give these data away through an interactive dashboard, so you can go into this dashboard to understand what's happening in a county, what's happening in a region, who lives in these particular areas, right? Your access to a particular clinic or park, or et cetera, all of those things will be included in that dashboard. And our private industry partner will be playing a really important role in that dashboard, but also through publicly available data sets. We're going to give these data away so that people can use them. We're going to share them. All right. So I mentioned our team. So we have this really incredible team, right? As I mentioned before, it's 16 scholars from 6 public institutions and a private industry team. The institutions include UA Fayetteville, obviously, UAMS, Southern Arkansas University, Arkansas State, UALR, and the Clinton School. Right? And then our private industry partner, which is CAP Index, they engage in crime risk assessment and loss prevention. They're leaders in that field and build these amazing interactive dashboards for private companies and for governmental agencies, and they'll be taking building that for us. So we're really grateful and excited about that. So I'm gonna walk you through the team. Everyone has a fancy title, so I'm not gonna walk you through all of the titles, but I'm just gonna kind of highlight who is on the team. So obviously myself is the PI, Dr. Anna Bridges from Psychological Sciences, Dr. Paige Dobbs from Public Health, Geosciences, Jack Cawthron, and Brad Peter. Our UAMS team, we have Dean Ben Amick, who's in the room today, Dean Mark Williams, and also Michael Thompson from UAMS. From the Clinton School, we have Nicola Driver. From UALR, we have Derek Slagle, Molly Smith, and from Arkansas State, we have Amanda Carpenter. And our newest team members come from Southern Arkansas University. And those folks include Dean Bakari, Abraham Tucker, Antonella O'Donnell, and Daniel McDermott. Right. So these are our team members from all of the different public institutions. And then our private industry team, Dr. Grant Dravi, who's in the room today. He's the Vice President for Geospatial Crime Solutions at CAP Index, and Dr. Casey Harris, who is the Vice President of Crime Risk Modeling at CAP Index. So this is a true public-private partnership, right? Again, this whole idea of bringing together a coalition of people to address wicked problems, right? And so they will take the lead on building the interactive dashboard. I should also say that this project would not exist without Dr. Dravi. So both Dr. Harris and Dr. Dravi were colleagues of mine in the department. 3 years ago, when no one was around on campus, we thought of this crazy idea. And we were just crazy enough to propose it to the chancellor. And so anything bad that comes from survey, you can blame Dr. Dravi. Just kidding. All right. So let me walk you through, well, actually, let me back up. So we also have some really amazing students that are part of this project, postdocs as well. Dr. Jessica Morgan, a postdoctoral fellow in sociology, Sydney Bingham and Logan Mann are graduate students in sociology and criminology, and Adi Timby and Laura Pinto are data science undergraduate students. This project would not be possible without all of these students, right? Sydney's in the room today. She went through thousands of lines of code with all of our income data. Dr. Jessica Morgan and Logan have interviewed hundreds of respondents for the Arkansas Health Survey, and Amy Timby and Laura Pinto have matched all of our survey responses to our larger sampling frame. So thousands and thousands and thousands of responses, right? Lots and lots of really important work, and we're really grateful for their support. We will also be bringing on 2 more students from Southern Arkansas University in the next round of interviews, which I'll talk about here in a bit. All right, so how did we do this? How are we collecting data? So we're adopting an address-based sampling frame. And what that entails is we purchased this really large sampling frame of 70,000 potential respondents in all 75 counties, their names, their addresses, their phone numbers, and their emails, right? And from that sampling frame, respondents, all 70,000, received 2 mailed invitations beginning in November through January. And then we have always planned on oversampling in the southern counties and in Pulaski and Northwest Arkansas. And I'll kind of walk you through why we're doing that. We always knew that we would see underreporting in the southern counties. So beginning on Monday, folks in those particular counties, Northwest Arkansas and Pulaski, will receive 2 more mailed invitations, right? 2 more mailed invitations before we have finished up data collection. From there, non-responses will receive up to 3 emails and 6 phone calls before we consider them a non-response. In terms of what they receive, folks receive a link and a QR code to complete this survey. We also give them an interview, a phone option, interview option, and a $10 incentive for completing the survey. Right. It's also important to note that folks have the option of completing the survey in English and Spanish, both online and on. And again, the goal here is a target sample 11,000 adult Arkansans residing in all 75 counties. Right? So as I said up here, we sent out 70,000 invitations, right? And so some of you might be wondering, like, what does that actually look like, right? This sampling frame is a representative sample, and it's stratified by age, race, income, education, and gender, right? And so here is the map of all of the counties in Arkansas, right? It's all 75 counties. And these points represent all of the invitations that we sent out, right? So we have blanketed the state with invitations to complete the survey, and we have done it multiple times, and we'll do it multiple times again, beginning next week. And I'll talk to you a little. We planned on doing this earlier, but we've had delays. I can talk to you about why we've had delays. All right, so what I want to do next is walk you through some preliminary findings. Obviously, we're still in the field, and so we have not finished up data collection. But want to walk you through a cut of data, right? So we've collected over 8,000 responses to date. So I'm going to walk you through some of the findings that we have seen up to this point. It's a cool little slide, right? Thank my partner for that. All right. So I'm going to show you some sample characteristics from 7,961 Arkansas Health respondents. So what we're seeing is an average age of around 46. Almost 68% of those interviewed self-identify as female. That's really common for a survey like this. Now, what's really important to note is that we will weight these data and write a report about the sampling weights. And so this will be a representative survey of the state of Arkansas and by county. In terms of racial and ethnic background, approximately 74% of respondents are white, 6% multiracial, 7% Hispanic, 11% Black African American, 2% Asian Pacific Islander, about 1% Native American Indian. Sexual orientation, approximately 8% self-identified lesbian, gay, bisexual. And in terms of family structure, almost half are married. It's really important to note that we have very detailed family structure measures. This just gives you a flavor for what we can actually do. We know folks, whether folks are divorced, single, separated, widowed, etc. Right? So we can provide a lot of really detailed information about family structure in the survey. We also have household information, approximately 2.7 people living in the household. In terms of education, approximately 31% had a bachelor's degree or higher, 15.4% associates, 42% high school diploma or equivalent, and 3.3% less than high school diploma. We also have very detailed income data. As I mentioned before, Sydney went through all of it. It's a monumental effort. And so we can create poverty thresholds in this survey because we have income data. We also have household and child data in the survey. And so at the time of the survey, approximately 16.6% of folks were living below the poverty line. But again, we can create these thresholds once we're done with data collection. So we can know whether or not folks are living 200, 300% below the poverty. So we will be able to know a lot more about economic deprivation in the state. In terms of health insurance, approximately over 90% of folks were insured at the time of the interview, and approximately 57% of folks were employed full-time. We also have very detailed employment information, right? So we can tell you whether or not they were employed full-time, part-time, if they're unemployed, why they're unemployed. And we also ask them about occupation type if they are employed. So we have very detailed occupation data in the survey that will take some time to clean, but we will release it eventually. All right, so the next thing that I'd like to walk you through are some of the main health seeking and access to care measures that we've included in the survey and kind of what we're seeing with these particular metrics. So the first has to do with going to the doctor in the past year. So approximately 85% of folks saw a doctor within the past year. So overwhelming majority of folks are going to the doctor every year. Approximately almost a quarter of folks sought care for a mental health problem in the last year. This will come in handy here in a bit. And then 65% of folks use the internet to communicate with the doctor. We have very detailed telehealth and telemental health measures in the survey. Right? So this is just kind of one of the major telehealth measures that we have. We have many, many more that we will be able to provide to folks throughout the state. In terms of access to care, almost 9% of folks had no place to go for healthcare if they get sick. More than a quarter had problems paying for or were unable to pay for medical bills. And then the next one that I'm going to show you is pretty concerning. This one has to do about worry for paying bills. What we're seeing here is that over 60% of folks worry about paying for medical bills. And then the final one has to do with transportation. From a lot of people in the state about transportation. 12% lack reliable transportation, not to just go to the doctor, but also just to go to work or any other kind of appointment. So this is general lack of transportation amongst our respondents. Okay. The next set of slides are going to focus on chronic conditions. We included 18 different chronic conditions in the survey. And I'm not going to walk you through all of them. Right? I want to blind you with a bunch of figures. But what I want to do is kind of walk you through what we can do with this survey, right? Here are 9 chronic conditions: blood pressure, high cholesterol, arthritis, asthma, thyroid problems, diabetes, cancers, and osteoporosis. And a lot of these percentages match up with statewide data, right? So you're like, well, what's different about this particular survey? And what kind of value are you adding here? Well, what we can do with this survey that we haven't been able to do with prior data is to determine whether or not folks are living with multiple chronic conditions and different types of chronic conditions. And what we know is that when you're living with multiple chronic conditions, you increase your risk for premature death, right? So what I did was I created a measure that looks at folks living with 3 or more chronic conditions. And what we're seeing is over a third of folks are living with or have a history with 3 or more chronic conditions. So a really high prevalence of folks, right? So it's important to look at all of these different chronic conditions, and we'll spend a lot of time thinking about them, etc. But it's also important that we can look at multiple chronic conditions in this particular survey. It's also really important to note that these patterns are not equal across different groups. And so what I want to show you is an example of what we can do when looking at patterns by race and looking at the 3 largest racial groups in the survey. So Latinos, Black Arkansans, and white Arkansans. And so this is a little figure. I know it's kind of busy, but the gray bar represents Latinos. The kind of lighter pink bar represents Black Arkansans, and the red bar is white Arkansans. And what you can see here is that there is a clear Latino health advantage in the state. With every single chronic condition, Latinos have a much lower prevalence of each outcome when compared to Black and white Arkansans, which matches up with a lot of national data. We've just never really had these data in the state to really understand it on a real level. Now, for Black and white Arkansans, the patterns are much more complicated and nuanced, right? We see a higher prevalence of hypertension for Black Arkansans, a high prevalence of asthma, high blood sugar, diabetes for Black Arkansans. But with cancer, right, significantly higher prevalence of cancers for white Arkansans. The same is true for arthritis and high cholesterol, right? So it begins to tell a very different and more nuanced story about disparities in health in the state and different types of conditions that we might want to think about differently for particular groups in the state of Arkansas, right? Now, what's also important to note is when we look at 3 or more chronic conditions, obviously Latinos have a much lower prevalence of 3 or more. For Black Arkansans, it's 31.8% reported 3 or more chronic conditions. For white Arkansans, it's almost 38%, right? 38%. So this will start to begin to tell us a very different story about chronic conditions in the state. All right, so I'm going to walk you through 3 of the behavioral health measures that we included in the survey. The first focuses on hazardous alcohol use or alcohol use disorder, and I can talk to you about how we'll measure this later. The second is tobacco and the third is depressive symptoms. And what we're seeing with hazardous alcohol use and alcohol use disorder is that almost 37% of respondents are showing signs of hazardous alcohol use and alcohol use disorder. This will come into play later, so kind of keep a mental note of that. Almost a quarter used tobacco in the last 30 days. And when we look at this particular population, folks who used in the last 30 days, overwhelmingly, the majority of them every day, right? And finally, with depressive symptoms, more than a third are showing signs of clinically significant depressive symptoms. And again, I can talk to you about how we measure that later. I also wanted to show you some patterns by race and ethnicity for these behavioral health measures, because this begins to tell us a different story as well. Remember, Latinos had a physical health advantage, right? With all those chronic conditions, we're seeing very different patterns when we're looking at behavioral health. So for alcohol use disorder, 38% of Latinos are showing signs of alcohol use disorder compared to 37% for white and 33% for Black Arkansans. For tobacco, 25% for white, 23% for Black Arkansans, and 22% for Latinos. And then for depressive symptoms, what we're seeing is that 38% of Latinos are showing signs of clinically significant depressive symptoms compared to 32% for white Arkansans and 37% for Black Arkansans. Right? So these patterns are very different, right? They're not uniform. It all depends on what we're actually looking at and the different types of groups that we're looking at. We can do this with all sorts of different social mechanisms, right? Gender, sexuality, income, education. We can begin to break these out in really meaningful ways to begin to understand how health shapes differently for different groups. All right. We also included a range of other social determinants of health in the survey. I wanted to walk you through 3 of them. So we included a short form survey to assess food insecurity in the survey. At the time of the interview, almost 33 or over 33% of folks were food insecure. There are substantial racial disparities here too, that I can walk you through later if you'd like. Almost 33% of folks showing signs of loneliness. And then we also included a range of climate change measures in the survey. The South will be disproportionately impacted by climate over the next 10 years. We just experienced major flooding in the state last week, right? So we asked folks about the different types of extreme weather events that they've been exposed to over the last 5 years and whether or not they had a negative impact on their lives. And what we're seeing is that over a third have been exposed to 3 or more extreme weather events in the last 5 years that have had extreme. All right. We also included a maternal health sequence in the survey. And just to give you an idea of how powerful these data can be, to date, we have surveyed 5,436 women in the survey. And of those women, 70.6% have a history of pregnancy. And we can tell you a lot about the number of pregnancies folks have had, the number of live births folks have had. We can also tell you about chronic conditions prior to pregnancy, right? So I want to walk you through some of those. So approximately 5% of women were told they had diabetes prior to their pregnancy. 11% were told they had a history of hypertension, 10% history of asthma, and almost 19% had a history of depression. All of these different risk factors play a role in preterm labor and postpartum, right? These are really important things to think about. What's also important to note is that we can use some of these measures to also predict current depressive symptoms or other kinds of behavioral health or other types of physical health outcomes, right? This just doesn't live in isolation. That we can really begin to holistically look at all of the different health outcomes and social characteristics in the survey to begin to tell a different story of Arkansas. In many ways, and I say this often, that this survey can be used to tell the story of Arkansas, both good and bad. Both good and bad. We also ask questions about support. And this isn't just if they have support from a partner, but if they have any sort of support, people to lean on, help them go to a doctor's appointment, help them cook, etc. And 14% of women reported that they had no support while they were pregnant in their most recent pregnancy, right? In their most recent pregnancy. Okay. So what I want to do now is walk you through some of the place-based variation that we're seeing in the survey. So again, this is an address-based sample, right? And so we know where people live. We sent surveys to their homes. We confirmed where they lived in the survey. So we can begin to see whether and how prevalence of different health outcomes varies by place, yeah? So many of you have probably seen a map like this before, right? Of looking at some sort of outcome by county in the state. Yeah, you can look at this on ADH's website. You're probably like, well, what's different about what you can do with the survey? Why are you doing this? First, I want to walk you through that currently there are 7 counties, and this is high cholesterol prevalence, in the highest prevalence category, where we have over 44 respondents responding, telling us that they have a history of high cholesterol, right? And it'll be really important to kind of think about what is happening in these counties, what is driving high cholesterol, in these particular areas. But I also want to point you up here to Northwest Arkansas. So Northwest Arkansas is always kind of in the lowest prevalence category or second lowest prevalence category, right? And the story around Northwest Arkansas is that there's significant advantage, economic and social advantage in this particular area. Why should you focus on Northwest Arkansas, right? Why should you focus on Northwest Arkansas? And many of those things are true, right? But when we start to dig into a particular area, we begin to see patterns very differently. And so what I want to do is walk you through some patterns when we look specifically at this region. And so what this is this is a map of high cholesterol prevalence by census tract in Madison, Washington, and Benton County. And remember, let me go back. We have 7 counties in the highest prevalence category, yeah, across the state. We have 16 tracts that are in that same category in Northwest Arkansas. And they're concentrated in Washington and Benton County, and they're in both rural and urban areas, right? They're in both rural and urban areas, right? So it begins to help us tell a different type of story and better understand how to localize potential interventions, right? To really think about this in a place-based way. I'm going to give you a couple of other examples, okay? So the next has to do with high blood pressure. So we have 14 counties that are in this highest prevalence category where you have over 50% of respondents telling us they've had a history of high blood pressure, right? So 1 out of every 2, right? 1 out of every 2. And again, they're spread out across the state, and it'll be really important to think about these particular counties, yeah? But look up here at Northwest Arkansas, light pink, yeah, no big deal. Let's not think about folks up here where we're living right now. When you look at the county or look at the census tract level, we actually have 9 tracts that are in that same highest prevalence category. And some are in the heart of Fayetteville, in the heart of Springdale, over here up in Gravette, in the heart of Madison County, and over in rural parts of Benton County, right? So it's spread out throughout the counties, yeah? Spread out throughout the counties, and it looks different based on rural and urban areas. Okay, so the final one that I'm going to show you has to do with alcohol use disorder, right? And hazardous alcohol use. And again, remember Northwest Arkansas, super light pink, yeah? Real low prevalence. We're seeing something very different with this particular behavioral health metric that I think you'll find pretty fascinating. We have since looking at these data. So this is alcohol use disorder, hazardous alcohol use in the state. And Northwest Arkansas is deep red, deep red. And so we have 8 counties that are in this highest prevalence category, where over 42% of respondents are showing signs of hazardous alcohol use and alcohol use disorder. Right? So let's look at the tracts, right? Let's look at the tracts. Let's dig into the tracts. When we dig into the tracts, we have 59 tracts that are in that highest prevalence category. It's almost all Madison County. It's a large chunk of Fayetteville, large chunk of Springdale, large chunk of Rogers, Bentonville, right? But not just in the population areas, it's also in rural parts of Washington and Benton, right? So obviously we will spend a lot of time thinking about this, right? Trying to understand what is happening in these 3 counties. But this just gives you an idea of what we can do with the survey. Right? This is the true power of the survey, and people will be able to access this information through a dashboard, right? Through a dashboard. All right, so as I mentioned before, we're still in the field. So I want to walk you through the timeline so you have an idea of where we're at, where we're going, when we'll be done. So we plan to be done in May with a target sample of 11,000. I can talk to you about the delays if you want to know. In June, we can we will compile the community and built environment measures and link them to this survey. By July, the data set will be finalized and it will be weighted. Beginning in August, hopefully through October, we'll have the interactive dashboard created. The team will review the dashboard, the data sets, and supporting materials in November, and then we'll release the data to the public in December. And then we start over. Right. We start year 2. When we start disseminating findings, you'll start seeing press releases about food insecurity and alcohol use disorder across the state, right? We will provide those to the public, but then we start collecting data in April of next year, right? In April of next year, but planning will start in a really serious way, December, January. Okay. So before I open it up for questions, really quickly, I want to thank some people. Okay. First, all of you for coming. Thank you. And all the people online. Hi. This project wouldn't exist without a number of really incredible people. Dr. Shana Morimoto was the first to give me some small seed funding for the project. That helped us write the proposal when Grant and I were thinking about this. And then I met with Dean Williams and Dean Amick, and Dean Williams was able to find us a substantial amount of seed funding for this particular project. Dean Kathy Sloan, the former interim dean, believed in this project and provided support for this particular project. And it's not just about the financial support. There are teams of people across this university at UAMS here in our department and have played a really important role in getting this thing off the ground. We have an incredible administrative person in our department who has helped send out over 8,000 gift cards to people across the state, right? Without these people, this thing would not be possible, right? It absolutely would not be possible. And the last group that I would like to thank are the advancement people, Becca Bradley and Julie Olson. I don't know if Julie's online.
Julie's on.
All right. Julie has been an absolute champion of the Arkansas Health Survey. It's been pounding the pavement, helping people convince them that this is an important endeavor. I am forever grateful to all of these people, right? That I will be up here kind of peddling this stuff a lot. People will get to know me more. There are a lot of people behind the scenes that believe in this work, believe in this team, and without them, none of this is possible. So I'm very grateful to all of them. Thank you, Julie. Thank you all of the people online, and thank you to all of the other people in the room. And with that, I will open it up for questions.
Outstanding, fascinating survey. Congratulations. I have few questions. First of all, really I have lots of questions, but I'll make sure that I don't take too much time. Is older adult oversample? Older adult, age 65
We
years.
didn't oversample for older adults, but it is so the sampling frame is a representative sample, right? So it's stratified by age, stratified by gender, education, income, and race.
Thank you. The national survey that shows that Latino are less likely to be diagnosed or treated for hypertension, diabetes, etc., etc. If the data was collected based on self-report, for example, for hypertension and diabetes, so I'm not surprised that the result shows Latino and African American are less reported diabetes, hypertension, etc. So is there any way that we can connect the data to, let's say, CMS, etc., etc.? Did you collect social security number or something that we can collect? Okay.
Yes.
So there is no way that we can connect. Okay.
I should also note that other large population health surveys that have also included biomarkers continue to show very clear Latino health advantage when compared to white Americans.
Okay, great. And also, the structure of survey is, it seems that it's similar to Enhance.
It is.
So congratulations, we can compare this one with the Enhance. That's a great thing that you have done. And finally, you answered my question that later this year you are going to make it publicly available.
Absolutely.
So there's no way that you can make it sooner to back up. Thank you so much.
We do have a question online here. First, Julie replied to your comment and said, an honor and a privilege to partner with you in this critical research for our state, Dr. Niño. And Dr. Mohsen Bazargan asked a question in the room. Dr. Shazi Bazargan, who is at Alice Walton School of Medicine and is online, asked a question as well. And she says, is there any data on injury, specifically traffic injury, considering the high prevalence of alcohol?
We have not included measures on injuries in the survey. And that's a great question, and it's an important one, right? I would encourage people if they would like to know more about the survey itself and what we're planning moving forward to reach out to us so that we can think about year 2, right? For instance, we're planning to include an oral health sequence in the survey in year 2. Right? So these things are important to think through. We'll have to think about if there is room or how we can fit these kinds of questions in the survey, but these are important conversations to have, and we welcome them forward. Ben?
Yeah, so I just want to add, we were having multiple conversations back here, sorry.
Yeah.
But the survey will be a public good. And one of the advantages over time that we've already started talking about is linking this information to other information in the state so that there's a single repository. And one of the groups that we will work with is the Center for Health Improvement that holds the all payers claims data. So if we can start to crosswalk with that, and that'll be a big discussion, that then allows us to look at some of these questions about hypertension and blood pressure in a totally different way because we have claims data. But that's down the road. First, we gotta
finish it up.
Julie and others have to successfully help us.
We have another question online. Eleanor Hughes says, this is a wonderfully collaborative project. This is great. Thanks for the presentation. I might have missed it, but how is it funded? I believe you said there are $10 gift cards for each completed survey.
Yep.
And also, how long do the surveys take? She's impressed with so many people willing to complete.
Yeah, so it takes about 20 to 25 minutes to complete. And most of the funding came internally through UA Fayetteville and UAMS and Southern Arkansas University. So again, folks believe in this work and have decided to invest internal resources in this project, right? Yeah.
First, thank you. I am Emily Richardson. I'm in the nursing school, but I'm really impressed with the number of doctor visits in the last year based on what we see as providers.
Yeah.
I'm curious if you're looking at what type of medical facility they're visiting. Are they seeing an urgent care, an ER, a PCP, a nurse practitioner? Because when we strike by race, what you see in the white population are those that require access to a specialist, cancer diagnosis, arthritic diagnoses, versus something that's more just diagnosed within an ER and urgent care. And so are you looking at that as well?
We decided not to include type in this survey, partly because of length, right? We were really concerned folks would not be interested in completing a survey that is over 20 minutes. We're finding that's not actually the case. And so we've learned a lot about what people are willing to, what types of information people are willing to give us and how long they're willing to spend time doing that. And so these are things that we plan to include in year 2, right? But we were worried about folks starting the survey and not completing it, which we have about 1,000 people who did that. We have about 1,000 people that did that, yeah.
How did you measure the depression?
We used the short item, eight item CESD scale.
It's quite interesting that the rate of depression among Latino and African Americans is similar to white.
Yeah.
But the rate of chronic condition is lower.
Yeah.
Because the way that both of these are measured is, self-report
Yep.
rather than objective measure. So that's quite interesting. So from my perspective, the depression scale, since you use the
Yeah.
validated instrument, is quite reliable.
Yeah, absolutely. The same goes for all of the measures, right? These were pulled from national population health surveys and from the NIH. We didn't make anything up in that survey, right?
Hey, Gustav Van William, visiting here from Karolinska Institute, Sweden. I'm a toxicologist and public health guy, so questions might direct that way. But when you're saying that you are talking about three conditions together, iron or, so have you tried to see that if there is a correlation between an individual group who have high cholesterol, high hypertension, this pattern, the high thyroid, because so that can be clubbed together as one, basically, they're very interrelated. And if they also have asthma, then it's really something different. So have there been any data set or data analysis?
We haven't done it, but we can. That's the whole point, right? Is that we have the ability to do it.
Out of my personal interest, I would say when you're talking about chronic diseases, you listed asthma, but not COPD, but COPD is very high here. It's like the third leading cause of death in our country. So do you have that data as well? And you have a very high smoking rate in the state. So. And smoking would be with everything of those.
And our tobacco measure, so that's just one of 5 that we included in the survey. Came from Dr. Pebbles Fagan at UMS, who's a renowned tobacco scholar. So those measures are really good. They're really, really good. They can tell us a lot about tobacco use in the state.
Last one I want to survive that you showed that it's a track, right, where you are seeing high cholesterol. And so I'm wondering from a more public health toxicology intervention studies is that now we know that PFAS increase is correlated to increased thyroid and cholesterol. So do you have a plan, or are you collaborating with somebody to measure PFAS in the waters, drinking waters, which can correlate to?
So not yet, right? So that's essentially why we did this, right? Is that now that we have these types of data, so we can better understand kind of place-based prevalence, that we can work with toxicologists and others to begin to think about, well, what's next, right? What's next? What could be driving some of these high prevalence outcomes in these areas? That's the true power of this, right? Is that this helps us better understand the starting point, and then from there we can really kind of dig in.
It's a fantastic data set that's been created. That's awesome. Yeah. And I had a discussion with Dr. Dobbs yesterday actually on e-cigarette and vaping things. But do you also incorporate nutritional data in this population? Is there any scope?
So we didn't include any kind of food diary type stuff in the survey, right? Partly because of length.
Thank you so much.
Yeah, of course.
I'm the senior research back here at the University of Arkansas. And thank you very much for a wonderful presentation. I'm looking forward to just here discovering the first blue zone within Arkansas. But my question is this, there's some other parallel kind of efforts going on. Dr. Niño mentioned the keyword convergence. And I know there's a global flourishing study coming out shortly. I think they've already released some data, but there's going to be a much larger announcement, I guess, in the coming weeks about the effort coordinated partly out of Baylor, Byron Johnson involved, Tyler Vanderbilt, I'm sure you're familiar with his work. And also we have a national effort underway through whatever Robert F. Kennedy Jr. is doing, and taking really targeted shots at very specific things where there's known problems, like pre-diabetic incidents of children. Can you comment on how that keyword Dr. Niño mentioned, convergence, how all this is going to kind of come together to formulate priorities?
So I think once we finalize data collection, the team will start to come together to think about what we want to prioritize, right? In terms of here's the press release on, say, for instance, food insecurity in the state of Arkansas, here are some key recommendations, et cetera, right? That's why we've built this team, right? So that we can bring together all sorts of different ideas on one, what we should be releasing first, but two, what's next, right? What's next in terms of that convergence, right? But we do see these teams growing, right? And also, because the team is spread out across the state, they can work with community partners in the southern region or in the northeastern part of the state, et cetera, to help people better understand what's actually happening in that region.
Thank you.
So we're just a couple things. We'll be able to continue the conversation here in the room.
Yeah.
I do think we are at time.
Okay.
It is 10, and I just wanted to say a couple of things. Dr. Niño, thank you so much for joining us today. Partners from SAU online, including Dr. Landry and others, and they just expressed how proud they are to collaborating with you on this project. And we will end the webinar, but we can continue the conversation here in the room. And of course, we just wanted to present you with a small little token of our appreciation for being here and giving us the opportunity to be the venue for presenting this data.
Yeah.
Thank you so much.
Yeah.
Thank you to those online, and we will see you for our next presentation on the 25th with Dr. Sitkar from George Mason University. Thank you.